I think we'll get started. Good afternoon, everyone. I'm Linda Resnick. I'm the Director of Learn, and I'm pleased to introduce today's presentation for our fourth year of our series, Using Health Systems Research to Revolutionize Rehabilitation Care. Please note, if you'd like to enable closed captioning for this webinar, there are two options in the Zoom navigation bar. You can either select Show Captions if it is visible, or if it's not visible, you can select More to access the closed caption feature, and then select Captions. You can then choose your preferred language. Today's webinar marks the 36th Learn-sponsored event. All of our previous events are archived on the Learn website, including Dr. Eva Woodward's recent presentation, 6 Mindsets to Promote Health Equity Through Implementation, Practice, and Science, and Dr. Allison Gustafson's Equitable Implementation of Innovations to Promote Successful Aging in Place. And you can see here all 6 of our 23-24 archived events so far. There is a link to the archive events in the chat, and you can view any of them on demand. So our speaker today is Dr. Suzanne Bakken, Alumni Professor of Nursing and Professor of Biomedical Informatics at Columbia University, and Editor-in-Chief of the Journal of the American Medical Informatics Association. Upon earning her doctorate in nursing at the University of California, San Francisco, she completed a postdoctoral fellowship in medical informatics at Stanford University. For more than 30 years, Dr. Bakken focused her research on the intersection of informatics and health equity. She has been funded by AHRQ, NCI, NIMH, NINR, and NLM. She leads the Center for Community Engaged Health Informatics and Data Science and co-directs Reducing Health Disparities Through Informatics, RHeaDI. I'm not sure I'm going to say this, RHeaDI, I think is how it's pronounced, and pre- and postdoctoral training programs at Columbia. She also serves as a co-lead of Columbia's FAST Healthcare Interoperability Resources Lab. She is a fellow of the American Academy of Nursing, American College of Medical Informatics, International Academy of Health Sciences Informatics, and a member of the National Academy of Medicine. And she's received multiple prestigious awards for her research, so we're really thrilled to have her. Dr. Bakken's talk today will be followed by a question and answer session, and during that time we ask that you please enter your questions into the Q&A feature of Zoom, and then we can address them once the talk concludes. After the presentation, we'll be providing a link to an evaluation survey, which we ask you to please complete. And we'll be also conducting a brief poll of participants to understand who's in our audience. And finally, we'll wrap up our time today by sharing some information about upcoming Learn events and opportunities. And with that, I am pleased to introduce Dr. Bakken to present Epistemic Justice in Advancing Health Informatics and Data Science Innovations. Welcome.
Thank you. It's my great pleasure to be here with you today and to be able to share a topic that I'm particularly passionate about. And so with that, we'll get going. Okay. So I know you can see my slides. I'm not advancing at the moment. Let me do it this way. One of the things I want to start off with is some definitions, because some of the concepts in this, the idea of the talk is really centered around ethics, but I am addressing some things which are technical. And so I do want to start off just with to give you a sense of some of the words you might be hearing and how they might relate to each other. And so often we might hear the words data science or big data. You may be hearing about machine learning. You might be hearing about artificial intelligence, that is AI, versus Informatics. And so you can look at this in a number, excuse me, through a number of different lenses. And the slide that I'm sharing really looks at it through the center, through the lens of AI. And the reason for that is there's a lot of hype around AI today. But in bringing things together, one of the important things to remember, it's just different sources of data. And so in things such as machine learning, we use numbers in data. In things such as natural language processing and the various methods associated with it, often we would use text as data as well. And then we do have other systems that use speech as data or use images as data. Coming from the informatics community rather than the artificial intelligence community, one of the things I would typically be making a distinction in would be through the years, informatics has involved a lot more on the human side, and as compared to some of the artificial intelligence approaches that are common today. But we're hearing a lot more now about putting the human in the loop or human-centered AI. But the main focus of the talk is really to continue your theme you've had from recent speakers, and it's really around thinking about health equity. And I'm specifically going to talk about it from the perspective of epistemic injustice. And so epistemic injustice is a wrong that's done to someone specifically in their capacity as a knower. And so we think about it as there's two subgroups of that. And testimonial injustice occurs when prejudice causes a hearer to give a deflated level of credibility to a speaker's word. And it could be what a speaker is, what somebody's actually saying, but it could be also words, images, etc. And hermeneutical injustice occurs when a gap in collective interpretive resources puts someone at an unfair disadvantage when it comes to their social experience. And some of this can be due to a lack of shared concepts or a misalignment between someone's experience and socially accepted concepts. So I want to take a mini poll. So as I mentioned, testimonial prejudice occurs when a hearer gives a deflated level of credibility to speaker's word. And this may be individual or structural prejudice. And so I'm asking you to raise your hand physically or electronically if you've experienced testimonial injustice in an encounter with the healthcare system. And I think people have experienced this in any number of ways. Certainly, many mothers have experienced it in taking their child to someone to look at, and the mom is saying, "This is not normal for my child," and the healthcare practitioner might be saying, "Don't worry." And so, this is one of the main concepts when we think about testimonial injustice. And then hermeneutical injustice has to do when you don't have common ground in communication. And sometimes this can be as, I've seen this a lot in my practice when I was a clinical nurse in critical care. And I worked in post-op open heart surgery. Particularly if someone was doing poorly, the medical team would come by. They'd say a bunch of stuff to the family, and the medical team would leave, and the family would say, "What did they say? What does it mean? What would you do? And what should I do?" And that's an example of people communicating in a way where you really don't have the shared concepts. Have others experienced this, either on coming at it from the clinical side or experiencing as a patient? Okay, thanks. So epistemic injustice, this idea came from a feminist philosopher named Miranda Fricker. And she did this book in about 2007, and then a few years later, we started to hear about it in the health literature, and some in a number of different areas. Some were simply in people's patient role as a patient, and once you were ill, your credibility about what was happening with you would perhaps be discounted. There's been a lot of work in the area of mental health and not valuing the patient's experience of their signs and symptoms in that area. Pain is another big area of research, and we're well aware that through the decades, symptoms of pain have often been discounted by clinicians, and we're in an era where there is more attention to pain management. So those are some examples in the health literature. There's also more recent literature that's really talked about it more globally, and really thinking about having the dominance of perspectives that come from the Western world rather than other ways of knowing. And this is something that I'm particularly interested in. I'm part of a collaboration that works with researchers in Kenya and Ethiopia, and we were recently funded by the Brochure Foundation to host a conference on this topic because it's incredibly important. And so once again, we're really thinking about who knows what and whose knowledge is valued. One of the main points of this talk is health informatics and data science innovations have the potential to mitigate epistemic injustice, but there's also potential to make it worse. And so there's a couple of things that are becoming more and more common. And I want to just briefly talk to you about that and some of the ways that they can make epistemic injustice worse. So I don't know how many people have experienced a chatbot. Probably most people have experienced in some type, you might not have necessarily experienced in a healthcare encounter, but you've probably experienced it somewhat frustratingly in some type of customer service event. And so how can the use of chatbots can be useful in healthcare, but what are some of the ways that it can make it worse? Well, when we look at all of these informatics and data science innovations, they're developed and trained on sets of data, and that's the foundation of the various predictions that they make. So in a chatbot, often they're giving you the best answer based on the training set to what your question might be. So we can run into issues with that in healthcare. It may work well for things such as scheduling and that kind of thing. But when we look at patients' symptoms, the individual may be experiencing symptoms that aren't in the training set or not be able to express them in the words that the chatbot can give an appropriate answer. Secondly, when we think about one of the things that there's a particular amount of hype about is generative AI. So when we think about generative AI, and you most commonly have probably been hearing about it through ChatGPT, that's gotten the most attention. But there are other types of innovations at all. And all of these different types of applications that answer questions and generate either text or images are also based on existing training sets. And so once again, one of the main issue in these is really around whose voice is missing. So we know with something, the most current version of ChatGPT-4 doesn't have data past 2021, to the best of my recollection. So one, the data is not up to date. And then secondly, it's heavily it's heavily represented by predominant voices in written text. And this becomes incredibly important because we think about whose voices aren't there and which makes it inaccurate in terms of the type of people you might wish to be communicating with. So it's important that we pay attention to that. More and more healthcare providers and patients within the context of a learning health system experience a growth in predictive algorithms. So this is when a computer, a set of rules is generated based on, once again, a training set of data, and then a prediction can be made about a particular condition. And so in some instances, it can be you're predicting someone's risk of dying. It could be you're predicting their length of stay and those types of things. But it's also been used to predict things such as your risk of opioid addiction, for example. And so one of the challenges with these types of predictive algorithms is that there's the potential that these can be considered the gold standard and that the patient's experience loses its credibility when it's in conflict with the algorithm. And once again, the algorithm doesn't know all the things about the individual. So anyway, there's a lot of work that needs to be done in this particular area. And I'm part of a committee at the National Institutes of Health called the Novel and Exceptional Technologies Research Advisory Committee. So we're dealing with these kinds of issues also from thinking about it from the perspective of equity. And lastly, there's a lot of work that's going on in digital phenotyping. And digital phenotyping most typically is the use of existing sources of data, often within the context of the learning health system. It's electronic health record data, and then putting together information about an individual or a group of individual that could potentially drive some type of care decisions or some type of risk calculation. So once again, we need to be fully aware that, these things can have the potential to hinder some communication, diminish the perceived value of the patient's experience and what's going on. And so I'm making you aware because there's really needs to be research in how these things are being deployed in healthcare. We do have strategies with potential to mitigate epistemic injustice. We can think about it from the perspective of individuals like me. We always do human-centered design of innovations. We typically use qualitative research methods to find out what people's information needs are. We co-design innovations with them. There's also citizen science approaches which are primarily driven by someone outside of the healthcare encounter, really understanding the patient's knowledge work and the work that they do outside of encounters, and have ways to integrate that into the ways of knowing. And an interesting project that's going on by investigators at my university and Columbia University and the University of Pennsylvania is they've developed some algorithms that predict an individual's risk of deterioration in the ICU unit. But now they're building in an additional data source not just what they're learning from the electronic health record, particularly the nurse's documentation, but building in the patient's perceptions, or the parents, this is for children, excuse me, the parents' perception, and taking advantage of what the parents know about their child and their child's response. And so that's an example of something that can be used to mitigate epistemic injustice. And then we also have technologies that promote access to data sources. I don't know how many of you have experienced open notes for your clinical encounters where you can read what your clinicians have documented about you, or those of you who are clinicians have your patients be able to read what you've documented. And then also thinking of different applications for increasing comprehension, analysis, and interpretation of information. And that's a lot of theory going into this, but it ends up being important background. But I'm going to make it real by talking about some of my research project through this lens of epistemic justice. And I'm first going to start out with a very old study. This is something I did about 25 years ago, but it was an important lesson for me. And we were working with an inner city community church called the Glide Church in San Francisco. And in its homeless clinic. And we had the opportunity to get a little money from the National Library of Medicine to implement a web-based information resource. And what we discovered at that point in time would be kind of a big duh today, but the websites were at such a high level of literacy that they were really impossible for the clients in the homeless clinic to understand them. So we really had to augment what they were doing with some nursing informatics students who could help with them as health information navigators. And it was really important in that with this additional help, some people did were motivated to seek additional training. And we had at least one big success story where someone went on to be a computer professional at the end of it. And so this is an example of really providing additional hermeneutical or interpretive resources to help advance things. One of my where I got into this big time was years later when I was at Columbia University, and I was a part of a project called the Washington Heights Inwood Informatics Informatics Infrastructure for Comparative Effectiveness Research, or WISER for short. And the basic idea of WISER was that we had disparate data sources, and we were going to pull all that data together into a research data warehouse, create a tool that would help researchers explore the data to improve the health of the community. But my big contribution to the project was really this arrow that goes to the community members. And this part wasn't in the original proposal, because what I wanted to do was to give the data back to the community members in a way that they could understand it. And we knew from the data that we had collected on about 6,000 Latinos in our community that there was a low level of health literacy in the community. And so that really led my team to thinking about visual strategies that we could use for communication to give these data back to the individuals who had generated it. So by visual communication, we're really talking about the conveyance of ideas and informations and forms that can be seen, plus comprehended, plus acted on for self-management and communication with healthcare providers, and by individuals with varying levels of health literacy. And importantly, because most of our data were collected in Spanish, it was important that we would do this in English and Spanish. And so we used an approach of creating a set of infographics, that is information visualizations, and a tool that would tailor the infographics with the person's own data. And this was a way to mitigate hermeneutical injustice and increase the individual's ability to understand their research results. We employed a human-centered participatory design of the infographics, and that was so we could incorporate the community members' lived experience and facilitate testimonial and justice as well. And so I'm just going to quickly show you a few infographics. This data actually comes from one of the I think one of the Centers for Disease Control common data elements, and it's around your fatigue level. And so one of the metaphors that worked well for our community was the notion of a battery. And in this particular infographic, we're trying to say this was your data, and this is other women in your age group for a comparison. We also wanted to let them know about their other health. And once again, the top line would be their individual data, and below would be other women in their age group. In some things we had, in some instances, we would be wanting to compare people with others in their age group. In some instances, we had measures that were against a particular criterion. So for example, this is a PROMIS score, patient reported outcome information measurement system score. And on all PROMIS measures, average is at 50. And then, and in this particular infographic, we're telling the individual what their symptom score was. And then we use the colors of red and green to show, in this instance of symptoms, less is better, and red to show that more of that. You'll see through our work, we use a lot of these number lines and the red, yellow, green color scheme to show this. And this is an example of where we were showing someone their BMI. And so we have multiple visual cues. We have the shapes of the body, we have the colors, we have the number line, etc. And we include a definition. We also wanted to give an overall sense of how different aspects of the individual's health work together. And I'd imagined the idea of a four-leaf clover. And so we worked on this so people could get a picture of their physical activity, their overall health, their mental health, and their fruit and vegetable consumption. And what we needed to do, and this went, we had 102 participants and about 18 design sessions. Most of them were in Spanish. But the things that we needed to do to make it possible for someone to understand this was to put these little dotted lines around it, because it's hard for people to visualize proportions without something to compare it to. And also to show them what a fully fleshed out clover or flower would look like. One of our comparative effectiveness project in WISER was focused on hypertension. So we did a lot of blood pressure infographics. And we started with things that were quite simple, with traffic light, red, green, yellow, many other things. In the end, the one that was most preferred and most actionable, perceived as most actionable by the individuals in our participatory design session, was this one, which was a little more complicated. And what it does, it shows one of the ways your blood pressure is measured, along with the individual's blood pressure values, the systolic and diastolic blood pressure coming out of that. Once again, you'll see the use of our similar colors pointing out where the individual's blood pressure is. But it was important to, it was particularly important to show why you would care. And so what you see with the body is an example of some of the potential side effects that can occur, the complications that can occur from having high blood pressure or hypertension. And one of the things that we purposely did is we included both the a common term as well as the professional term, because we felt like some of the providers might be talking to them in diagnostic terms, but we wanted them to have the mapping between it. When we did this, everyone got their set of infographics, a pile of them that they could write on and do whatever they wanted with. Some people gave them back to us, but I think this was the one that people took out of the room the most. And I just imagine this under a magnet in many refrigerators in Washington Heights, because even if they didn't have hypertension, they felt it was important for everyone to know, and they likely knew someone who had it. But it was important that we would design the infographics, but it was important that we had to come up with a way to be able to produce them at scale. So we created a system that we initially called ENTICE-3, which stood for Electronic Tailored Infographics for Community Engagement, Education, and Empowerment. And the basic idea, it's shown two different ways here, is we have a set of data, we have some graphical components, and what the system does is it puts them together to produce the tailored infographic. Because it was important to us, we wanted to not do something generic but for people, but to return their individual information. Through the decades, we worked on a number of different projects, refining our methods. We've done a lot of work in dementia caregiving, for example. But when most recently, and I'll spend a little more time on this particular project, early on, we had the idea of, yes, we've designed infographics, we've created a number of methods that we've refined through the years to be able to do this more efficiently. We've designed some software, and we really wanted to create a toolbox that could be used by used by other researchers to do the same things, or could be used by healthcare organizations or community-based organizations. And so we finally had the opportunity during COVID. The NIH created an initiative called the Rapid Acceleration of Diagnostics for Underserved Populations, or RHeaDI. And so this gave us the opportunity to apply some epistemic justice informed approaches to address initially COVID-19 testing, and eventually vaccination as well. And so the basic idea is we wanted to take what we had learned through about a decade of research, put it into a toolbox. As input, it would take the information needs of particular clients. The output would be tailored infographics, and we could do it at an individual or batch output. And in addition to the software and the infographics, there would be different types of documentation that would help people to do this. When we submitted the grant, we conceptualized a variety of users, but because the COVID response in New York City was very community-based, we ended up really focusing most of our attention on community-based organizations. And so what we wanted to do in our project was to decrease COVID-19 disparities through using culturally congruent, health literate infographics and that would support comprehension, informed decision-making, and motivate appropriate behaviors. We did this through collaboration with a number of community-based organizations, in addition to a number of units at Harlem, the Association to Benefit Children in Harlem, and that was primarily addressing the health disparities of African Americans and Latinos. And then we worked with New York University and two additional community-based organizations to Project New Yorker and Chinese American Planning Council, because Bangladeshi and immigrant Chinese were also health disparate in terms of COVID-19 testing and vaccination. And so that means that we ended up doing our project in 4 languages, well, depending, data collection in 5 languages, English, Spanish, Bangla, Mandarin, and Cantonese, and written things in simplified Chinese, in addition to Spanish, English, and Bangla. And so just a little bit about the project. It was very community engaged. We collected data from almost 1,000 people. We had bilingual staff. And then we did additional qualitative work and participatory design. So this gives you just a little bit of information about what we learned. And very importantly for us, and thinking about the design of a resource that would reduce hermeneutic injustice, was our numeracy question. And you see the question on the slide: which of the following numbers represents the biggest risk of getting a disease, 1 in 12 or 1 chance in 37? And so although education varied a lot in our sample, 34% answered the numeracy question incorrectly. And this ended up being very important when you think about it from the perspective of chance of getting COVID versus chance of side effects from the vaccine, the sensitivity and specificity of the various tests. These are just showing what people cared about in terms of hesitancy and vaccine motivators. I think you, having lived through the pandemic, these would be expected from you. Thinking about trusted source of information, healthcare providers came out first, and thankfully social media came out last. And you'd see a little more than 50% trusted the government. It was very important to us that although we learned some things from a lot of things from the survey, we really learned a lot from our qualitative work. And these were some that were particularly important. A misunderstanding about how the vaccine worked, speed of development was a significant concern. Worry about long-term effects for self and offspring. And this was particularly predominant among the younger people that we sampled. And this was something that was not really covered in the survey. For some, they felt that the vaccination conflicted with the religious beliefs. There was a concern, particularly in thinking about vaccination, of individuals wanting to wait and see about the effect on, look at, for example, vaccine side effects on people like me. So seeing the data in average didn't really help individuals that weren't well represented in the data to understand what their odds of getting a side effect might be. And there also was a lot of concern, particularly in our Harlem sample, around the prioritization of communities in color. And so this is an actual quote: "Are we the guinea pigs? White people usually get everything first." And so although it wasn't the intent of the vaccination rollout, it was the intent was, of course, to get it out to the communities that were most effective, but this was the perception of a number of people. As I've met with groups in the community to disseminate our study findings, people have absolutely resonated with this, and they kind of added to it, and that was people who lived in public housing said, well, when it came to prevention, we would get a few masks, one little thing of hand sanitizer, and then all of a sudden, so they felt like they got very little assistance with prevention. And yet when it came to vaccination, there was enough for everyone to have it. And so I think that's been interesting. But how did what we learned through this intensive community engagement help us with the infographics designed? Well, we learned that we needed to be clear about the different types of tests. We had to provide information about vaccine mechanisms and platforms. We had to address key hesitancy concerns about particular populations. And we had really gone into this thinking that culture would make a big difference, but at least in our looks at the data so far, age has been much more important. So younger individuals, particularly those more in childbearing age, had different hesitancies than the older population. It was also important thinking about allowing branding from a trusted source in the community. So Columbia can be seen as a good source of evidence, but these community-based organizations who are out there on a daily basis were incredibly important. So I think of my short tagline is that we develop high-tech tools for high-touch workers because they're the ones that are trusted in the community. We wanted to support cultural congruence through ability to change colors, change pictures, those types of things. And we also needed some options for communicating risk and proportions because 1/3 of the sample got the question about risk wrong. So we knew that was important to do. We did participatory design in a couple of different ways. We first do a broad survey, usually 100 people at least, and ask them to rate some different images and which they prefer. And then we go into the co-design of the actual infographic itself. And in this instance, early on, we workshopped two different approaches. And one was a more traditional textbook approach, and one what was considered a personified approach. In the end, the personified approach won. I was a little concerned when we were first going through this because I thought a personified approach might make people think that it wasn't serious, but there was such a strong preference. So even though I'd been a little hesitant, we moved forward with that. And this slide just shows you our vaccination infographic. So in this, we show how the virus makes you sick and how the vaccine works, because those were key pieces. Those were key pieces of information, and then putting some motivational aspects in that. And often when you're doing these types of things, it's very important to find a conceptual metaphor that works well. And so for us, it really was the concept of a war and it being a battle. And more specifically, there certainly is a, depending on how big of screen you're watching on, you may see like some of these infographics at the bottom have lightsabers. So there's a little bit of Star Wars influence in it as well. And then as far as the tailoring to the information needs, in addition to having the standard information that everyone gets, depending on the their particular information needs, they can get some additional modules. You can see this is related to children and breastfeeding. This deals with, I've already had COVID example. And then lastly, we went into our toolbox. You've seen the toolbox have 3 different names, or the software have 3 different names, starting with Entice 3, which is about the software, and then we called it the RheaDiViz toolbox for a grant, but it turned out there's a database software called RheaDiViz toolkit. So it was too close for us to be using the name. And what our toolbox really does is to assist with the tailoring of the visualizations. And so we changed its name to TaylorViz Toolbox. And this is just to show you it's a simple web-based system. It starts with a catalog of the various infographics that we have, and then at the organization level, people can do things such as brand them, change out the pictures if they want to edit text. They can choose the language of the infographics as well. And so we have the infographics in English, Spanish, and then also Bangla and simplified Chinese. We've had the opportunity to further this particular research, once again, looking at it from the lens of epistemic injustice. We were creating tools that would help people make sense of their experience and the guidance from the government and other places, and also take into account their particular needs. It was important coming at this from the informatics perspective that whatever tool we developed would be scalable and extensible. And we've had the opportunity to do that with collaboration with the All of Us research program. So the All of Us research program is our US precision medicine initiative. They've collected different types of data from over 800,000 people. The goal is 1 million, but they expect to exceed it. And this includes survey data, electronic health record data, and for some people, also genomic data. The IGNITE program, which is a grant that I'm involved with, is really focused on returning value to the community from the use of the All of Us research workbench. So this is a different emphasis than having an individual get back their results. So there's a lot of things that the IGNITE grant does, but one of its primary mechanisms is to do outreach to community groups and to researchers, etc., through these different types of experiences with the data. And the most common thing is often a data sandbox. So a group of people come in, they do different activities, including something like a treasure hunt to discover something that is of interest to them in the All of Us researcher workbench, which is the mechanism by which you can access the data. And so what we're doing in this particular, in the aspect of the grant that I'm involved with, is if somebody has a data sandbox, for example, and they've done the exploration of it, we will have created a infographic template related to the particular topic. The one we're working on now is pre-diabetes, and so prevention of diabetes when you're at high risk for it. And so this returns value to the community in that, in addition to them learning how to use the research workbench to learn some things that might be of interest, they also get can get some software and a starter infographic that could help them meet some needs of the community. And so this is an example of a strategy to mitigate hermeneutic injustice. And so in conclusion, advancing health informatics and data science innovations through the lens of epistemic injustice suggests the need to do a variety of things. One is to broaden the diversity of input, inclusive of the lived experience, into the implementation of data set, both the development and the implementation of data sets, algorithms, and innovations. We need to develop strategies and tools that facilitate stakeholder determination and prioritization of health-related resources to meet those needs. We need work to really, it's fine to say, yes, every stakeholder it'd be great to do co-production, et cetera. But it's really important that we have strategies that help people learn how to do co-production, translation, dissemination, et cetera. And then importantly, we need to apply or develop data science policy frameworks that support epistemic injustice. In terms of the last, I'm currently working on I'm currently co-leading a group at the National Institutes of Health that's called Engage. And it is out of the Office of Health and Science and Technology Policy, which is a component of the NIH Director's Office. And what the Engage initiative is focused on is we're charged to come up with a framework and a toolbox that will help scientists better engage with the public throughout the phases of the clinical research process. And so that's a 2-year charge. We started about 6 months ago, so it'll be out about 2 years from now, but there'll be some particular opportunities for public engagement that I can certainly follow up and share with you, so you have the opportunity to chime in on it. I'm just acknowledging some research funding and important community partners and experts that we work with in this. And the slides include some references to some of the work there. And now I'll turn it back to Linda. Thank you for your attention.